Hello, everyone. I'm thrilled to be joined with my colleagues today for the Lung Cancers Today roundtable discussion. My name's Millie. I'm a medical oncologist at Stanford University. I'm going to have my colleagues introduce themselves as well.
My name is Stephen Liu. I'm a medical oncologist at Georgetown University in Washington, D.C.
And I'm Martin Dietrich. I'm a medical oncologist with the U.S. Oncology Network in Orlando, Florida.
My name is Singhi. I'm a thoracic medical oncologist at MD Anderson Cancer Center in Houston, Texas.
All right, so thanks for joining me. I think that we're going to have a really great discussion. We're going to start off by talking about young onset lung cancer and molecular alterations in non-small cell lung cancer. And so I'll start with you, Eric. I just wanted to find out, I know this has been a topic of interest for you, and as we're treating these patients with lung cancer in our clinics, I have noticed over the years that we're seeing patients who are younger and younger at the time of diagnosis. Is this something that you are seeing at MD Anderson, and what are your thoughts on this?
Yeah, absolutely. I think we're seeing this nationwide and internationally as well too. So traditionally, the average age of diagnosis of lung cancer has been closer to 70, right? And we picture these older males who have a heavy smoking history, and that's been the traditional face, if you will, of lung cancer. Well, that has really changed over the last 2 decades. We've started to see younger patients. We define young onset lung cancer as a community generally as ages 50 and younger, right? And we're starting to see this rising incidence, particularly patients who have no smoking history, patients who are often females, and it's such a disruption in their lives. So on average, this is a little bit outdated. It's about 10% of patients now being diagnosed with lung cancer in our country. So that's rising. Almost 20% of patients currently being diagnosed with lung cancer have never touched a cigarette, have no smoking history. So we have to redefine that image and talk about it as a community.
Yeah, and Stephen, I think you and I have been in practice maybe a bit longer, and so as we see these patients who are younger at the time of diagnosis, we're seeing them presenting with advanced stage disease because a lot of times no one's really thinking about lung cancer when they're coming in with their symptoms, and so they're being diagnosed later on, and we know that there's a higher incidence of driver mutations in these patients. Is this something that you're also seeing? And how do you think about these patients who are younger and have never smoked?
Yeah, I think it's something we don't talk a lot about. And even though lung cancer is a common cancer and it's the leading cause of cancer-related death in this country by far, it's something that's not really in the public narrative. And so as a result, it's not considered by patients, by family members, by physicians. So often we'll see someone who in retrospect clearly had symptoms related to lung cancer for quite some time, months even, and they'll be treated for adult onset asthma, allergies, community-acquired pneumonia, and finally, someone does imaging and we find a lung cancer. But your point's important. These are different cancers. Cancers changing, not just in terms of the typical patients that we're seeing, but it is a different biology. And these non-smoking related cancers do tend to have a higher incidence of actionable genomic alterations. At the DNA level, these are different cancers. And as a result, they need to be treated differently. And I think we're finally starting to be able to do that.
Treating these patients in our clinic, are there, Martin, I'll ask you, are there things that we should be doing differently as we're thinking about some of the physical and the psychosocial circumstances of these younger patients compared to older patients? How do you approach these younger patients maybe a little bit differently from the older patients?
Yeah, absolutely. I think there are many facets that are differently in the younger patients. I think one is, we talked about the enrichment of molecular alterations in younger patients. So our testing pattern really has to be intensified. The pretest probability in a never smoker to find an actionable alteration is well over 50%. So we really have to make sure that we get liquid and tissue biopsies with DNA and RNA-based platforms to really look for the more common and the rare alterations that may drive these cancers. They may not have as many mutations as a smoker, but some very impactful ones that are potentially actionable. So I think that's a great opportunity for us. And there are other factors that are important. That is to match the therapy to a lifestyle of a younger patients. Most of the patients at that age are employed. Many are having families, have young children, and some of them are desiring to have children. So fertility discussions are in the challenge as well. So there's a lot that goes into it, and not only diagnosing these patients and matching them to their respective therapies, but also to adjust to their individual individual psychosocial context is a very in-depth discussion that we oftentimes don't have to have in patients that are older, that have different life circumstances at the time. So it requires a lot more time. There's a lot more stress on these patients. So supporting them both somatically and psychologically, I think, is very important, and to connect them to the proper resources, the patient support groups, to exchange how to deal with a diagnosis unexpected and oftentimes associated with a sense of surprise and the stigma of lung cancer, even when a patient has never smoked before. So I think there's a lot to be done for patients that are diagnosed in a never smoking setting, and whatever we can do to support, I think, is most important for them.
Totally agree.